I hope everyone is here and that everyone can hear me. I'll wait for a couple of minutes to admit some more people. Good morning to all again. Just one more minute of waiting. I hope everyone can hear me also. All righty. All righty. Good morning, everybody. This is Dr. Russell Brown. We are presenting our case study review meeting. Let me see here. I have some more people that need to come in. All righty. We're getting started on our case study review meeting. Um, Today, we'll be discussing self-harm and suicidality. And once again, the purpose of these meetings is to, as required by the state of Georgia, we're supposed to provide you with some pharmacology training. And this is done to meet that commitment to all the MPs and PAs that we have on board here at Avinia. This also helps with notation and documentation as well. Um, just want to let you know there are a couple of textbooks that we utilize, um, and I need to be transparent. One is Psychiatric Case Studies for Advanced Practice. The authors are Kathleen M. Prendergast and Casey Jackman, and this is, I believe, the first edition of this book. Some other books that we've added are Child and Adolescent Psychiatry Clinical Cases by a Dr. Alcides Amador, MD. And then we also use Case Files Psychiatry, which is the sixth edition of this book by Dr. Toy and Dr. Clayman. Just wanted to give that full disclosure there. Um, all righty. Let me see who else is in the lobby waiting to be admitted. All righty. Hopefully everyone can hear me. We'll go ahead and get started with this case study. All right. Identification. We have a patient that's a 16-year-old Hispanic female. She's referred to the emergency department um, for evaluation by her school guidance counselor, and um, and subsequently referred for an inpatient hospitalization. The chief complaint is, I told my friend I was hurting myself. History of present illness or history. The chief complaint, the patient told her friend at school that she had been self-harming by making cuts to her left arm and that she wanted to die. She states she cuts herself after arguments with her mother because it helps her to feel better. Her mother would not let her go out with her friends and um, expects her to take care of the house and her younger siblings. The patient started to have suicidal thoughts about a month ago. And excuse me, I'm just admitting some more people to to the meeting. The patient started having suicidal thoughts about a month ago, and the thoughts have been increasing in intensity since then. She currently has a plan to overdose on over-the-counter sleep medication that her mother keeps at home. The patient reports difficulty focusing in school and the recent loss of energy. She reports crying daily at home and denies any history of symptoms of mania or hypomania. Past psychiatric history. There are no previous psychiatric hospitalizations. The patient was in outpatient therapy about 6 months ago because of depression and anxiety. She stated that she had stopped going because of insurance issues and because the insurance did not cover it anymore, and her family could not afford to continue to pay for treatment. There are no previous psychiatric medication trials. Um, Medical history, there are no known allergies, there are no acute or chronic medication problems or medical issues. She has a regular menses. She's not using any type of birth control. Her parents report poor sleep and reduced appetite over the past month. She is not intentionally restricting her diet. Her height and weight are within normal limits, and she has some superficial healing lacerations noted on her left arm. History of drug or alcohol abuse. The patient denied any use of alcohol, marijuana, or any other illicit substance. Um, Family history. The patient's mother is from Ecuador. Her father is from Puerto Rico. The patient was born in the United States. She lives at home with her mom and her three younger siblings. The patient's father returned to Puerto Rico about 4 years ago, and she has had minimal contact with him. Her mother works for a catering company. The patient's mother has a history of depression, which is treated with Prozac. Her maternal aunt and grandmother, too, may have depression. There is no reported psychiatric hospitalizations or family history of bipolar disorder. Personal history. The patient was a normal full-term vaginal birth, and she had no complications at that time. Childhood, she has no developmental delays or learning disabilities. Adolescence, the patient states she gets A's and B's in her classes at school. She does not require any special educational accommodations. However, her grades have declined significantly in the past month. She identifies as bisexual and denies any current intimate relationship. She does have a history of sexual activity with both male and female peers. Trauma and abuse history, the patient denied. So I'll stop right here. Ask any questions. Uh, if there are any questions about the history, does anybody think that we need any more history? You can just speak up. Is there any other information um, that we, you know, anything else that we need to know to help make the diagnosis from a subjective or historical um, perspective from the patient or her family members? Is everybody satisfied with the amount of information that we've garnered from the patient?
I just got here, so I missed a lot of what you were saying in the beginning.
What's that again?
I was saying I just got here, so I missed all of what you were saying in the beginning.
All right then. Yeah, it's a 16-year-old Hispanic female. Um, she presented to the emergency department. She was referred by her guidance counselor. She has a history of self harm. She's been cutting herself uh, superficially, um, but she does have a plan to overdose on some over the counter sleep medication that her mom keeps at home. One of the stressors is that her mom won't let her go out with her friends, and her mom expects her to stay at home and take care of her. three younger siblings. She's had some previous psychotherapy, but never been on any kind of medication. Um, um, there are no past medical problems, no drug use, no history of any mania or hypomania. Um, Past personal history is uneventful. Um, and I guess the main take home point here is just the suicidality. Um, um, Whether we should take this as a serious set of events or we should just look at it as more or less acting out. Um, at this point, it should be taken seriously. She is cutting herself, and sometimes people cut themselves. That could be some acting out behavior. And we will get into that a little later on in the discussion. But I think it's the fact that she has a plan and she admits to one. Um, Overdosing on the sleep medication, and they are available in the home. Um, and she's been thinking about this with increasing intensity. She says that's probably why she was referred by the guidance counselor for um, for inpatient treatment. Hold on, I got some people to admit to the meeting here. Let me see if I can get them in. Right there, I think I got them in. All righty, so we'll go ahead and move on to the examination part to the mental status. If anybody doesn't have any more comments about the history section. All right, so mental status. She's casually dressed. She has adequate grooming and hygiene. Her bangs are dyed blue. She has normal gait and moderate eye contact. She's alert. She's oriented to person, place, and time. Um, Her memory is not formally tested, but appears to be intact during the assessment. Her attention is intact during the assessment. Her visual spatial ability is not assessed. Um, Abstract thought, not formally assessed. She has good intellectual functioning and vocabulary. Her speech is quiet volume, low pressure, and underproductive. Um, she has no evidence of any perceptual disturbance. Um, she's denied any hallucinations. She's denying any hallucinations. Her thought processes are logical and coherent. Um, Thought content, she's preoccupied with anger about having to take care of her siblings. So this is a stressor that she's kind of hanging on right here. Um, she's at odds with her mom about that. Suicidality, she has suicidal ideations with a plan to overdose on over the counter sleep medication, which she has access to at home. She reports uncertain intent to act on this plan. So we have to take that seriously. And I'm pretty sure this is why she's on an inpatient unit at this point. Her mood is depressed. Her affect is congruent with the mood and is constricted. Impulse control is poor, and which is definitely important to assess because if she has poor impulse, uh, she could have a flash of anger, sadness, or whatever, and go grab those pills. Judgment, insight, and reliability are poor, but her reliability is fair. Um, so, based upon getting the mental status exam, making these objective observations, um, anybody, is this satisfactory? Does anybody have any more, um, anything else that they would like to do with the mental status? Any other information that they would want to gather on the MSC? Yeah, I think this is a solid mental status examination and well documented. All righty. If nobody has any questions about the MSC, we'll go ahead to the medical decision making section of the report. Um, and this is formulating the diagnosis. Uh, the question here is which diagnoses are diagnosis or diagnoses that should be considered. The author has two here. One is major depressive disorder, single episode severe, and the other one is not current in the DSM-5, but it's referred to as non-suicidal self-injury, NSSI, non-suicidal self-injury, and we'll talk about that in a minute. Okay, so let's look at the diagnostic criteria for major depressive disorder. They have to have five or more of the following symptoms. They have to be present during the same 2 week period, and it needs to represent a change from previous functioning, and at least one of these two symptoms must be present. There needs to be a depressed mood, and there needs to be loss of interest or pleasure in activities. So, those are the two anchors for this diagnosis of major depressive disorder. Uh, note A note here is that do not include symptoms that are clearly attributable to a medical condition. So if there's a medical problem going on, and some of these criteria or these symptoms or could be related to that, uh, you have to diagnose this as a organic depression or a mood disorder secondary to that medical issue. So let's let's go over the symptoms. One, they must have a depressed mood most of the day. Nearly every day is indicated by either subjective report, feeling sad, empty, hopeless, or by observation made by others. Uh, they appear tearful. And note that in children and adolescents, this can present as an irritable mood as opposed to a sad mood. Okay. Number two, there's markedly diminished interest or pleasure in all or almost all activities most of the day, nearly every day. Hold on, I need to admit someone into the meeting. Um,
Can I
market,
ask you a quick question? Sorry,
yeah,
don't mean to
yeah,
interrupt, but are they formulating it as a single episode because there was no prior history of any depressive episodes? In case I missed that.
yeah. But I mean, it's interesting that you bring that up because she did have treatment before, 6 months ago, because of depression and anxiety. So you may want to question that.
So yeah, so that wouldn't really be a single episode
That
then.
wouldn't
It
be a
would be more
simple episode.
current.
Yeah, exactly. So the book made a mistake here. But that's why we're here to discuss all this. Glad you caught that. Um, so there's number two is there's markedly diminished interest or pleasure in all or almost all activities most of the day, nearly every day, as indicated by either a subjective account or by observation. Three, significant weight loss when not dieting or weight gain, um, e.g., change of more than 5% of body weight in 1 month, or a decrease um, or an increase in appetite nearly every day. Um, note that in children, uh, this weight modification can be or criteria is considered may be considered a failure to make expected weight gain. So in children, you just may not um, meet your mark as far as your weight based upon your age and height. Criteria number four: insomnia or hypersomnia nearly every day. Um, Five, psychomotor agitation or retardation, nearly every day, observable by others, not merely a subjective feeling of restlessness or being slowed down. So it has to be observable, the agitation or the retardation in movement. Number six, fatigue or loss of energy nearly every day. Number seven, feelings of worthlessness or excessive um, or inappropriate guilt, which may be delusional nearly every day and not merely just self reproach or guilt about being sick. And you see, the sense of worthlessness is more prominent in adults. And that sense of pathologic or inappropriate guilt, you generally see that in the geriatric population. Diminished ability to think or concentrate or indecisiveness nearly every day, either by subjective account or observed by others. And nine, recurrent thoughts of death, not just a fear of dying, recurrent suicidal ideation without a specific plan or a suicide attempt or a specific plan for committing suicide. And this young lady does have a plan, so we need to. I would take her suicidal ideations fairly seriously. Uh, and those are criteria A of the diagnosis. Criteria B, these symptoms cause clinically significant distress or impairment in social, occupational, or other important areas of functioning. In this area, in her condition, it's the other areas academic because her grades are going down. And C, the episode is not attributable to the physiologic effects of a substance abuse or another medical condition. So, all right, and these criteria represent a major depressive episode. Okay, um, what is the rationale for this diagnosis? The patient's symptoms include depressed mood, loss of appetite, insomnia, loss of energy, diminished ability to concentrate, and recurrent thoughts of suicide. Therefore, she reports more than five of these symptoms required for a diagnosis of major depressive disorder. They have contributed clinically significant distress and impairment of her academic functioning. Her symptoms are not attributable to the physiological effects of a substance or to a medical condition. In addition, the symptoms are not caused by either schizophrenic or psychotic disorders, and her symptoms have never included a manic episode. And I did. There were some other criteria I did skip that we did mention here. You know, the occurrence of the major depressive episode is not better explained by schizoaffective, schizophrenia, schizophreniform, delusional disorder, or any other psychotic disorder. So you have to eliminate that in order to make the diagnosis of major depressive disorder. Um, and there's never been a manic episode or a hypomanic episode. Um, and if there is one, then we would have to change the diagnosis to bipolar 1 or bipolar 2. Um, and um, so those are the five criteria that help establish the diagnosis of a major depressive episode. Does anyone have any questions about this diagnosis, how it's been established? We did state that this is probably recurrent because she's had this condition ongoing for at least 6 months. Any other concerns about the diagnosis of major depressive disorder and the criteria?
No.
All right. Are there any other conditions that should be considered? And this is going
Um,
to go ahead.
I'm thinking, I mean, I don't really, I'm just throwing this out, but I mean, there was you mentioned earlier that her mom is expecting her to um take care of, I guess, things at home. Could we also consider an adjustment disorder? But the thing is, since she's had a major depressive episode in the past, would that automatically just push away an adjustment disorder consideration because she's had depression in the past? And this would just be something that would trigger the onset of another episode.
Well, just by definition alone, an adjustment disorder, um,
Stressor related.
yeah, yeah, and I guess with the diagnosis of adjustment disorder, you've is 6 months. So she does meet that criteria, but the intensity of the
Mm-hmm.
symptoms is really the thing. The fact that she's suicidal and um, um, uh, and this has gone on for 6 months. So
Mm-hmm.
it's something
More
more than just
severe.
a, yeah, more severe because of the time and the intensity of the symptomatology. And the one thing, that I would always hang my hat on is um, the suicidal ideations that she's having. Um, so I think that's more than just an adjustment disorder. But that is something. Um,
It could be something to consider because I mean, in the DSM, does it? I don't recall seeing where it. And obviously being very realistic with how the patient is presenting, I'm just throwing out a possible differential, but it doesn't necessarily exclude suicidal ideation from an adjustment disorder, does it?
that the
There isn't an
DSM,
exclusion.
right? So meaning that you can have an adjustment disorder and still have suicidal ideations.
Right.
I'm not clear on that. I'm gonna have to look into that. That's a good question. Mm,
So
that's
let's just
never.
say, for example, right?
Hmm.
Maybe a woman who has no prior history of depression, you already screened for that, screened for any prior medical history, and they're coming in after being with their husband for 15 years. And they were under the impression that the relationship was great, but now found out that the husband has had maybe 10 other partners during the course of their relationship. And she's finding out about all these things. And it feels
Hmm.
like her entire world is crashing and
Hmm.
she's having thoughts of really wanting to die. And there is an identifiable stressor.
Hmm.
In that case, would you automatically die? And this maybe just happened over the past month, right?
Hmm.
Over the past, let's just say over the past 3 months, right? Because,
Hmm.
the symptoms of an adjustment disorder are supposed to appear within 3 months of a stressor happening.
Hmm. Hmm.
So let's just say in the case of that person who now has thoughts of wanting to die, with maybe, she's saying that she wants to maybe go jump off a bridge, something like that. In that case, there is an identifiable trigger for that person. So would we automatically say that this is going to be MDD and not an adjustment disorder because of suicidal ideation? If we know that prior to that episode or prior to that very stressor happening, there were no other symptoms or history of depression. So I'm just trying to, think from a
Hmm.
standpoint of, does SI automatically mean that um it is automatically MDD and excludes adjustment disorder? Because like you said earlier, the non-suicidal self-injurious behavior can happen where people have cut or self-harm because of intense feeling and wanting to relieve that and not necessarily wanting to die.
Right.
So I'm
Right.
just thinking
Right.
outside the box here because of how the patient as a possible differential. It obviously for her very well sounds like major depressive disorder, a recurrent episode. But I'm just saying if to think outside the box, is that a possibility as well? And would really SI mean that absolutely SI is no, it rules out adjustment disorder immediately.
Right. I would say that just because a person has SI, that doesn't necessarily mean that they have a major depressive disorder. It's just the
Right. Mm-hmm.
intensity of it
Mm-hmm.
and how pervasive it is. And
Okay. Yeah.
if it's stressor related, um, just in the history, it just states that this young lady, what does it say? Yeah. Patients started to have suicidal thoughts about a month ago, and the thoughts have been increasing in intensity since then. It's
Mm-hmm.
just the pervasiveness of the suicidal thinking, and the suicidal
Mm-hmm.
thinking may not be tied to like any type of immediate stressor, meaning that my mom says, I gotta go take care of my little sisters and I want to go out to the
Mm-hmm.
party, so I'm gonna start cutting.
Right.
What I pretend here is that she's doing that every day, regardless. Even though the fact
Mm-hmm.
that she has to take care of her little sisters all the time is always there, it
Mm-hmm.
doesn't go away. but it's this is more of a pervasive, um,
Mm-hmm.
ongoing set of symptoms that may that that may not be that aren't absolutely tied to that stressor, even though that stressor is ongoing. You know,
Right,
um,
right.
yeah, she's always that way, and it's getting worse. So it's not really reactive; it's pervasive and ongoing, and just as the rest of her symptoms are. The school performance, the other. Um, the other issues that they mentioned, loss of
Mm-hmm.
appetite, the insomnia, decreased energy, you know.
Mm-hmm.
But you could put it in there, and I would say that adjustment disorder is something that may not necessarily need to be medicated, because if you
Right,
remove the
right.
stressor, they should get better. Um, Obviously, the stressors here for this young lady are ongoing. I mean, she can't bring her daddy back home, or her mama just can't go get a new job and can stay home and take care of her siblings and allow her to kind of have normal peer group engagement and behavior. Uh, you
Mm-hmm.
know, so it's a question mark. But I think here they're going to err on the side of a major depressive disorder as opposed to a reactive adjustment disorder
Eating
because
disorder.
because
Okay.
of the symptoms. All right, but you do bring up some good points.
Yeah, and the
So,
reason I even asked that question is because I have this patient who had a had a reaction to a very, very stressful job.
mhm.
So they've been at the job since I've been seeing him for since 2024. He's been at
Uh-huh.
this job. He cannot perform according to the expectations or what is required for that particular position. He's been
Mhm.
on several performance reviews, and it has been the very thing that has been the source of the depression or the sadness that he experiences. I mean, his entire conversations revolve around that one particular thing. But at this point, essentially, when you're looking at an adjustment disorder, it's supposed to be time limited. When the stressor is removed, the symptoms are supposed to go away within those 6 months. Now, for
Right.
this patient where the stressor is chronic, do you now say, I am going to switch the diagnosis to now a major depressive disorder and no longer an adjustment disorder? Because I mean, an adjustment disorder could be chronic if the stressor doesn't go away. So in that case, do you change the diagnosis or do you leave it?
You generally, if it's ongoing and greater than 6 months, you would want to reconsider the diagnosis, even though the stressors, you know, occupational, social, whatever, are still going to be there. Um, um, if it's ongoing, and you see that, and it's pervasive and
Mhm,
worsening,
mhm,
I would go ahead and jump and make the diagnosis of a major depressive disorder. And it's kind of like I would look at it the same way we look at acute psychotic reaction versus schizophreniform disorder versus schizophrenia.
mhm,
Something goes more than 30 days, you got to switch it to something else. And if a set of
mm.
symptoms go on for more than 6 months, then you need to, relabel it.
Okay,
And
that makes sense.
yeah.
Okay.
Um,
Um,
but this does,
I would just like to say,
oh, go ahead.
I would just like to say with the a situation you described with a gentleman with a job, I would say too, like with therapy, even if the stressor is still there, like with psychotherapy, it should help reduce some of the symptoms. So I would think, if
Yeah,
he
it
is,
hasn't.
yeah, if he's in
It
psychotherapy
hasn't.
and trying to get other treatment, and it's
Hmm.
not going down, then that would be cause to, switch the diagnosis itself.
All right. And that's a good point because psychotherapy um, is therapeutic and it should change some of the symptoms. And if there's nothing going on there to improve it, then you got to consider maybe another diagnosis. Now, is this particular patient you have? Is he? I didn't hear. Is he on medication,
Yeah,
antidepressant
yeah,
medication?
he is on medication. We've, made several switches, but again, which, sometimes it just brings me to the question of, the whole validity of the DSM-5, because, or even what we know about mental illness itself. When you talk about chemical imbalances, or is it really because of chronic inflammation, or is it really maybe GABA? Like, because we've tried so many different combinations of things changing from one class to the next. And I know for him, the very onset of those symptoms came from the fact that this job, he has continued to perform poorly. He wasn't like this at all before he
Hmm.
started this job. So now I know that the very thing that is triggering this feeling that he has is that the stress coming from the fact that if I lose this job, I can't take care of myself. I can't seem to get the job done. I'm getting
Hmm.
a write up. I'm about to eventually lose this job if I don't get it together. And
Uh-huh.
I'm not meeting the expectations even after he's been put on a performance review plan.
Wow.
So he's basically entire life is hanging on that very thing
Hmm.
over the next 6 months and how he performs. So in a case like that, he's in therapy, but the therapy is really going to be teaching the patient how to manage, more so manage the stress, help, challenge the negative thoughts that come with it. But the reality is, this is what is going on. So for a person like that, would an antidepressant really improve your symptoms? Is the big question mark. It has not.
That has not. Is there a family history of mood disorder?
No.
Mm. Mm. Interesting set of circumstances. I mean, the stressors there is chronic, but does he have neurovegetative symptoms?
He's definitely so. There are changes in his sleep patterns. I mean, he's on Manjaro because he's diabetic, so obviously he's not eating that much. But just not having pleasure, interest in doing anything, low energy, poor concentration. All he thinks about his entire life basically revolves around that one thing. That's no matter how much I try to redirect the conversation or even do CBT, explore other areas of his life where a lot of how he sees himself as a man is attached to his performance in areas in his life, whether it's academics or work. So it's affecting his self worth and even how he engages with his family. So I can see in that case, considering major depression, but would an antidepressant help this person? When
If
he
you
was
found that,
off work, when he was off work and had a break, like I ended up having to take him off work because I mean, now it was progressing to, would it be better if I wasn't here anymore? Like more so passive ideation. When he was off work for that time period, he got better. And as soon as he
Mhm.
went back to work, same story.
Gotcha. So there was an improvement in his mood state when
Presentation. Hmm.
when the stressor was, and how long a time period was that?
He was out of work for about 12 weeks, 3 months.
And you saw an immediate improvement.
I saw a progressive improvement.
Did he get back to baseline?
Yes, he got back to, he was welcoming his son. He had a child, newborn, becoming a new father. He
Hmm.
was able to get back to re-engaging. But I stress that because I know that very thing that is making him the way that he is that job. Which I mean, again, with major depression, it doesn't mean that sometimes maybe symptoms can be triggered, an episode can be triggered by something, or it could just be completely random. So,
Right. Well, it sounds like he may not have it because if he came back to baseline and it was
yep.
just a removing a stressor, if someone had typical major depressive disorder, removing the stressor isn't going to change anything. I mean, it may change things a little bit. They're still going to, and if they're untreated, they're still going to have those neurovegetative signs, and they're still going to be depressed. I mean, they're just because it's organic and it's not
Hmm.
necessarily situationally or environmentally induced. Even though the environment and situations have a lot to do with what we see, but it's still, you know, quote unquote a monoamine deficiency state that they may be having, and that needs to be corrected. And it's biological because there's, and in certain cases, it's genetic and heritable. So yeah, I'm not sure
Or
what this
maybe
guy
we could
has.
also say atypical. I mean, depression can have atypical
Yeah,
presentations too, so that could be another consideration for him.
yeah. But I normally hang that diagnosis of MDD on neurovegetative signs,
Hmm.
and just like what you said, when they get out of the situation, do they get better?
Hmm.
And if your guy doesn't have a lot of intense neurovegetative signs, and if they do get better, whichever neurovegetative signs he has, if they do get better when he's removed from the stress, then you may want to consider something other than a biological major depressive syndrome.
Hmm.
All right, and especially if they're unmedicated too. If you don't have them on anything and then they get better when they're when they hit the lottery, or they get out of a bad marriage or something like that, or they get away from a different job. That's a lot different.
Hmm.
But anyway, let's go ahead and talk about this non-suicidal self-injury um, syndrome, because I'd never really heard of it before. But there is no current diagnostic statistical DSM-5 code for this condition, non-suicidal self-injury. It is listed in the section for conditions for further study in the
Hmm.
DSM-5, and here are the proposed criteria for this syndrome. And the last year, the individual has had 5 or more days engaged in intentional self-inflicted damage to the surface of his or her body of a sort likely to induce bleeding, bruising, or pain, e.g., cutting, burning, stabbing, hitting, excessive rubbing, with the expectation that the injury will lead to only minor or moderate physical harm. There is no suicidal intent. And note, the absence of suicidal intent has either been stated by the individual or can be inferred by the individual's repeated engagement in a behavior that the individual knows or has learned is not likely to result in death. Now, do you think this young lady here? See, I don't know if she meets this kind of acting out kind of behavior because, um, with the cutting, with the cutting, well, I guess with the cutting, she knows that that's not lethal, and she
Hmm.
probably is alleviating some pain. But the cutting, with the fact that she had been thinking about taking those pills and they're available, and she has a plan, that takes it to a new level. So I don't know if she would just meet the criteria for this
I don't
non
think so.
non-suicidal self-injury. And here's some more criteria. And we can go in further and discuss criteria A. Criteria B, the individual engages in the self-injurious behavior with one or more of the following expectations: to obtain relief from a negative feeling or cognitive state, to resolve an interpersonal difficulty, what she's doing, to induce a positive feeling state. And there's a note here: the desired relief or response is experienced during or shortly after the self injury, and the individual may display patterns of behavior suggesting a dependence on repeatedly engaging in it. So, in this criteria, you know, if her mama says you can't do something, and then she goes in the room and starts cutting herself, you know, and then she does that as a pattern to relieve stress, either this particular stress or other stressors, then yes. But once again, the overhang is that there's some pills and she's thinking about taking them. So if the case didn't present with the pills or her thoughts of taking the pills uh, as a way to end her life, I would probably put her in this NSSI kind of category. And there's a few more things that we can criteria that we need to go over, and then we can discuss it as a whole. The intentional self-injury. This is criteria C. The intentional self-injury is associated with at least one of the following: interpersonal difficulties or negative feelings or thoughts, such as depression, anxiety, tension, anger, general distress, or self-criticism, uh, occurring in the period immediately before the self-injurious act. Two, Before engaging in the act, there's a period of preoccupation with the intended behavior that is difficult to control. Three, thinking about self injury that occurs frequently, even when it is not um, acted upon. And then there's criteria D, the behavior is not socially sanctioned, it's not tattooing or body piercing or part of a religious or cultural ritual, and is not restricted to picking a scab or nail biting. E, the behavior or its consequences cause clinically significant distress or interference in interpersonal, academic, or other important areas of functioning. F, the behavior does not exclusively occur during a psychotic episode, delirium, substance intoxication, or substance withdrawal. In individuals with neurodevelopmental disorders or intellectual disability, the behavior is not part of a repetitive stereotypic behavior such as head banging or rubbing that those kids get involved in. The behavior is not better explained by another mental disorder or medical condition, psychotic disorder, autism, intellectual disability, Lesch-Nyhan syndrome, stereotypic movement disorder with self-injury, trichotillomania, which is hair pulling or skin picking, and excoriation disorder. So, there is this quandary uh, that you're always getting when kids come in, and I'm pretty sure a lot of y'all may be. I may have y'all on assignment with where there are a lot of kids, or even in your own private practice, you see kids, but they do come in with this SIB behavior, self-injurious behavior, and you're just not sure, is this suicidal behavior or is this just a way to relieve stress or possibly get attention? And you're always stuck with that. So um, I think in this case, it may be something more than that. Um, does anybody have any feelings about that in this case?
I agree that it's definitely more than just wanting to get attention.
Hmm. Hmm. Um, but it's not necessarily the way that she wants to end her life. But she could easily do it because she could just cut one of her arteries and bleed out. But so in that sense, she's not using it as a way, using it with any lethality. Uh, she's using it to relieve stress or dysphoria, and obviously it works because she keeps going back to it as a technique. But it's just something to consider. Now let's read what the author says about the rationale of this diagnosis in this case. She says the patient here meets the proposed criteria of engaging in intentional self-inflicted harm to her body, cutting of a sort that may induce pain, with the expectation that the injury will lead to only minor physical harm. And that is true. Because she's not doing it to with any lethality or finality. Uh, she's engaged in the self-injurious behavior with the intent to resolve interpersonal difficulty with her mom. The self injury is associated with depression and angry thoughts before the behavior, and that may be related to her mom telling her she can't go out with her friends. Um, the cutting is not socially sanctioned behavior. It does not seem to cause uh, clinically significant distress at this time. It is not associated with substance intoxication, um, psychosis, or a neurodevelopmental disorder. Therefore, if NSSI were a diagnostic category in the next edition of the DSM, she would likely meet the criteria. So, just based about how this thing is defined, she would have it, but outside of that, I would say she still has suicidal ideations that may be serious. But this particular behavior itself could be its own diagnostic set. Does that make sense?
Yeah.
Yeah. But that it doesn't exist yet. Maybe in the DSM-6 they'll make this a separate set, and I think they probably need to because I know I see enough kids who engage in this behavior, and we gotta just lump it in with something else as opposed to making it its own diagnosis. But I often hear, "Yep, she's a cutter. She's a cutter. She's a cutter," and you're thinking, "Oh my God, does that mean that they're suicidal?" And it doesn't, and they're not really doing it with any lethality because they've been doing it for a long time. And you look at their arms and you see all the lash marks, and you're like, man, if you really wanted to hurt yourself, you would have done it. And they're just doing it for the to relieve whatever any type of anger or dysphoria or disappointment that they may have, in life. But you know, that doesn't mean that they could make a mistake and and end up creating an accident and fatally injuring themselves. Um, any comments about uh, this this criteria or this diagnosis or this syndrome?
I was just going to mention, I think that's the part that gets primary care a lot. As soon as they hear SI, they automatically think, oh my God, this patient is about to go kill themselves right now, without actually doing further assessment. So, them
Hmm.
even knowing things like this could be helpful in their own clinical practice. That cutting
Right,
doesn't necessarily always equate to immediate or imminent risk in that moment.
right, right. And the person doesn't have to be immediately taken to the emergency room for
Yes.
a psychiatric admission. Yeah. And it took me a while to get kind of used to that too, because I used to always start shaking. Oh my God, we got a cutter here, and this that means that they're suicidal, imminently suicidal. And the longer I practiced and saw that these kids didn't, you know, they would come in there and tell you, "Oh, I was just mad," and cutting myself helps me feel better. You know, and you hear that a couple of times, and you think, "Oh, okay, then this is a syndrome in itself." And I don't know whether it's learned behavior with these kids if they see somebody else do it, and that's why they won't engage in it. Lord knows, but it is a thing, and we see it enough, so you, they're gonna officially make it a diagnostic category. All right.
And I think also, like, even considering the biological component that comes with cutting, like when people actually cut the way that it may or does release endorphin, similar to when a person actually has physical pain, that
Hmm.
it can relieve that emotional pain. That may be the very reason why they're cutting without really an intent to die, but that the cutting relieves whatever emotional pain
Hmm.
that they feel.
Right. All right. And yep, I agree. I agree. So, what tests or tools should be considered to help identify the correct diagnosis? Overall, the patient interview will be used to assess the extent of suicidality. Uh, the therapeutic alliance and detailed interviewing are the best means to evaluate symptoms in the inpatient setting. However, using the Hamilton Depression Scale is another option. And there is a self injurious thoughts and behavior interview, SITBI, can be used to assess self injurious behavior. So there are some tools that we can use other than the interview. Gathering collateral information from the family and previous hospital records would be integral to assessing the patient. Because of the short stay in inpatient units, it may not be practical, however, to obtain all the school records and talk to the teachers or previous outpatient providers, even though these would be useful sources of information in formulating the diagnosis and subsequent treatment. Um, what differential diagnosis should be considered? The author here puts none, but we talk about adjustment disorder. Um, uh, Formulating a treatment strategy. What treatment would you prescribe and what is the rationale? So we'll start off with psychopharmacology. Here, the author recommends Prozac 10 milligrams daily. Uh, this medication is FDA approved to treat major depressive disorder for ages 8 to 18. And they also say consider naltrexone 25 milligrams for the self-injurious behaviors. Naltrexone is used off-label for self-injurious behaviors, and the patient should be monitored for an increase or decrease in the self-injurious behavior. And that is because if when you there's SSRIs have a black box warning that when given to preteens and teens, they can actually become more aggressive, and that aggression could be directed towards self and result in more SIB behavior, or even a true suicide attempt. So you always got to be careful when putting these young people on an SSRI. Diagnostic tests, all routine blood work and a pregnancy test should be undertaken. If symptoms of sexually transmitted infections become apparent, then appropriate testing and referrals should be made. Referrals, because the patient is currently hospitalized on an inpatient unit, a family meeting with a social worker will address any psychodynamic stressors. Patients should be referred for continued medication management and psychotherapy following discharge from the psychiatric hospital. Type of psychotherapy, group therapy with peers on the inpatient unit should be undertaken. As far as psychoeducation, there is an FDA warning on all selective serotonin reuptake inhibitors, SSRI medications, regarding the risk of increased suicidality um, when prescribing this antidepressant medication to people up to the age of 25. And I didn't realize that that black box warning went up to in the 20s, but it does go up to age 25. Um, Educate the patient and the family about the medication and psychotherapy to improve treatment adherence and address any concerns they may have. Uh, as far as standard guidelines that one would use to treat or assess this patient, the American Academy of Child and Adolescent Psychiatry has a practice parameter for the assessment and treatment of children and adolescents with depressive disorder. So you could use that as a standard to make sure you're on the right track with the with treatment. And as a clinical note, cultural influences, including gender expectations, may contribute uh, to additional stressors to certain ethnic populations. This should be evaluated on a case by case basis. Cultural awareness is vital in treating patients and families who are members of minority populations. And I guess the author put this in here because this is a Latino family, uh, uh, presumably Catholic, and the mom may you know it may affect um, treatment compliance, being on medications. Um, certain populations are anti-meds, more religious. So you just have to broach those areas and see uh, how the family system engages the treatment process, and if they have any other ideas about what should be done um, about being diagnosed with a mental disorder, how you treat it, you know, to try to and use that psychoeducation um, um, as a way to keep them in the process, and whatever things they may use culturally, bring them into the treatment arena also. So it doesn't become an all or none situation. Um, so are there any comments about the treatment strategy? Um, is there anything else that should be done, um, medication wise, therapy wise, psychoeducation wise? Anybody have any thoughts?
Question about the medication.
Uh huh.
Did you say naltrexone to address the cutting, the self injury?
Right.
Is that true
Yeah.
for both? Does that work for adults as well? Or is it just something that's recommended for children?
Oh, it works in adults also. I've used it in adults.
Oh, okay. Thank you.
Yeah, I mean, but we give it primarily for children to deal with the endorphin release, to block that release that they would feel from cutting, and in adults they use it um, more or less for substance abuse, so they won't feel, drinking or whatever. They won't feel the high from a substance, and that may help kind of blunt that, cut that reward circuitry that's going on, and they'll be less apt to repeat that behavior. It works in some, it doesn't work in others, but it's something to add.
Yeah.
What's that?
Oh, no, 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 no. I was even going to add on top of that what you said, that it's also notable that it's not FDA approved, but just looking at the idea of how it works for alcohol and substances,
Uh
it
huh.
would essentially work in a sense of anything that it could work for something that is more an impulse control issue as well. Because I've had a situation where I've considered that for a patient who has like an addiction to pornography and just hypersexual behaviors, and it significantly helped.
Oh, really? I
Yes.
think that's good. Yeah.
Yeah.
That person's pretty hardwired, so you able to kind of
Yes.
break that circuitry up, and
Mm-hmm.
yeah, interesting.
Can
Yeah.
you repeat, ma'am? Can you please repeat what you said? I didn't understand you.
Oh, the patient, the one that I tried it with has a addiction to pornography and just very deviant sexual behaviors. So I just thought from a standpoint of, because it's FDA approved to use for alcohol use disorder and opioid use disorders, that it could essentially help for something that is related to an impulse control issue or something that provides some type of gratification. Because when you use naltrexone for alcohol, when people drink, what it does, it helps with the cravings and the feeling that you get while drinking alcohol or using those substances. So if you're drinking on top of naltrexone, you probably won't feel any high from the alcohol, but it doesn't mean that the physiological effects from the alcohol is not going to affect you. So that was my rationale for trying the patient on naltrexone, and surprisingly, it helped them.
Oh
But it's
wow.
not
Was it
FDA
time?
approved for that particular condition, though.
Oh wow. Okay, that's
Yeah.
that's good to know. You started at 25.
Yes, yes. And I ended up going to 50. And something notable that I even want to mention is that when they actually looked at increased risk of suicidal ideation when children are put on antidepressants, there's actually no proven study that shows that there is increased risk of suicidal ideation or self-harm with children versus the people who are not considered to be in that population of kids. And I actually read that somewhere and I was shocked. So the
Mhm.
FDA actually put that label warning on there as a general precaution versus it actually being proven to cause increased suicidal ideation. And a good book that you could read that would really open your mind up to a lot of what we know and don't know about psychiatry is a book called Unhinged by Dr. Carlat.
That's all good
Thank
information. That's
Yeah, thank you.
hmm Thank you, thank you, thank you. All right. And are there any other questions or comments about the treatment plan, the care plan? I got a I got one more thing. I got another short case study with some questions I just wanted to go over. I want to add these case some questions after each case study just to hammer in some points. All right, and we got a case here, just a paragraph, and then we got five questions. It's a 14-year-old girl presents with her mom for an evaluation. She's currently taking venlafaxine XR, Effexor XR, 75 milligrams a day, um, and Abilify, 5 milligrams daily. She started both medications about 3 months ago. um, after not responding to treatment with Prozac and Lexapro 6 months ago. Um, she started, uh, oh, well, after not responding to the Prozac and Lexapro. And then 6 months ago, she started isolating herself from friends and family. Her artwork changed from positive drawings to negative drawings. She no longer seemed as interested in things and felt tired despite being able to sleep over 11 hours a day. So she has some really hardcore neurovegetative signs. Her mood was irritable, which is different from her usually present pleasant mood. And we just state that kids express depression as irritable mood as opposed to sad mood. Her grades at school decreased since she could not focus on her schoolwork. She attempted suicide before being started on medication. She reports her blood, she reports her mood is somewhat improved, but she still does not feel like herself. So we basically got a 14-year-old, suicidal behavior, neurovegetative signs, currently on Effexor and Abilify. She failed treatment with Prozac and escitalopram, Lexapro, and she started having symptoms 6 months ago. So she's kind of beyond the adjustment disorder thing. She's in the area where we could flip the diagnosis over to something more permanent, like major depressive disorder. So here's some of the questions. What is the diagnosis or diagnoses? Choose all the answers that apply. We got major depressive disorder, bipolar 1 disorder, disruptive mood dysregulation disorder, social anxiety disorder, none of the above. We've been talking about major depressive disorder all morning, so the answer should be A. Per the history, major depressive disorder is the most appropriate answer. Okay. Question number 2. What metabolic labs did you order to monitor for aripiprazole or Abilify's possible metabolic side effects? Choose all the answers that apply. So we're looking to monitor um, Abilify. A, urine pregnancy test. B, vitamin D. C, hemoglobin A1C. D, thyroid stimulating hormone, TSH. E, lipid panel. And the answer here, with this being an atypical, even though it's not one of the strong ones, is C and E, uh, hemoglobin A1C and a lipid panel. Explanation: antipsychotics are known to have metabolic side effects. The most appropriate answers are check the lipid panel and hemoglobin A1C. All right. Question 3. Which medications that the patient has tried, which medication that the patient has tried has the shortest half-life? Aripiprazole, venlafaxine, Lexapro, or answer D, that all the half-lives of these medications are equal. And the answer is out of the listed medications, venlafaxine XR has the shortest half-life. I don't know what the half-life is, but the fact that it's an extended release must mean that they have to put it in some type of um, uh, release system to extend its half-life. So that must mean that the original that the originating half-life of the compound, without being in that matrix, must be short. So that's kind of the giveaway on that one. The fact that it's an XR, um, it's in an XR format. And venlafaxine generally is given BID, whereas most other um, antidepressants are given just a single daily dose. Question number 4: which medication that the patient is taking is most likely to cause akathisia? the Abilify, the Effexor, Lexapro are all are equally likely to cause akathisia. And obviously, akathisia is related to antipsychotics. So the answer must be A. Out of all the listed medications, Abilify is the most likely to cause akathisia. Even though, like I said, Abilify is both an antagonist and an agonist at the dopamine receptor, it's not as strong as the other antipsychotics. It's still an antipsychotic and could possibly cause some akathisia. And akathisia is just the motor restlessness, the feeling to just get up and move, tap your legs, tap your knees together. That people, that patients get when they're sometimes on these antipsychotics. And one more question, then we're done. The patient and parent report that in addition to medication, um, um, the patient has been also receiving psychotherapy where her therapist has been having her examine her automatic thoughts or automatic thinking. Which of the following treatments is she likely to be receiving then? CBT, DBT, IPT, which is interpersonal therapy, or psychodynamic psychotherapy, or E, none of the above. Anytime you see somebody working on automatic thoughts, that's always CBT, cognitive behavioral therapy. Um, in cognitive behavioral therapy, this involves examining cognitive distortions and recognizing automatic thoughts that are negative. Um, all right. Any questions about these questions about this case? Are the answers?
The part where it was asking, but I mean, I would assume that since she's already been on the medication, they probably did that. But someone who is of childbearing age,
Uh huh.
you would probably want to do a urine pregnancy test before putting them on some of those medications.
Yep. So
Yeah.
so so in addition to the lipid profile and hemoglobin A1C, also get the urine pregnancy test in a female.
Mhm.
Yep. Good point. Good point. Any other questions or concerns or issues, illuminations? All right. I think I've taken enough of your time. We had a good discussion, and I'll pick another interesting topic. I think next time I want to, I'm working with a lot of these medication assisted treatment centers for opioids. So we'll probably do something on opiate addiction. Okay.
Mhm. Do we have access to that book that you're using?
Yeah. I'm going to get the staff to email you that so y'all can actually preview the studies. It should be and they should be in all of your protocols that we send out. They should be the study guides that I use, but I'll have the team email this out to everybody that I supervise and any extra person that comes back and forth on a regular basis. But now they're four texts. Um, they're all case study books, and they're pretty good. They're pretty good. They're not always right all the time, but they give us food for thought, and we can extrapolate from how the authors make a diagnosis and go from there. But I'll get that out to you guys. Um, any other questions or or concerns? All right, then. Well, if that's the case, um, we'll uh, we'll go ahead and end the meeting for today. And I want to thank you guys for attending. And I will see y'all next month. Okay.
All right. Thank you so much. This was
Thank
very
you.
informative.
All right then.
Mhm.
Bye bye.
Thank you.